Vicki Segro is it's a mouthful, Rocky Mountain Movement Disorder Center. She is her and Dr. Kumar, one of our great partners, and she's here to talk today about medications and treatment.
If you all can't hear me, just start waving or shout or something like that. So usually I can talk pretty loud, but sometimes I do kind of drift off a little bit. So anyways, this talk is mainly to discuss pharmacologic treatments that we have now available for Parkinson's disease. We do a lot of research at my center, and I'm gonna at the end touch a little bit on what is coming and may be coming in the pipeline. Okay, this is not cooperating again. Do you know which one I'm supposed to be pushing to make it? Oh, there we go. Now it just miraculously started. Yeah. So first of all, there's a lot of different classes of medications to treat Parkinson's disease. The gold standard we have is a drug called carbidopa, levodopa, or Sinemet. It's been around 50 years. It's still the best drug that we have to treat Parkinson's, but we got a lot of other medications to augment and also help with motor fluctuations. COMT inhibitors, we have monoamine oxidase type B inhibitors. There's dopamine agonists. There's a drug called amantadine, anticholinergic medications, which we really don't use a lot anymore. And then new class, adenosine receptor antagonists. And we're going to kind of go through class by class. So levodopa is by itself half of Sinemet, right? So levodopa is the most potent treatment we have to treat Parkinson's disease. If you take levodopa by itself, it's very poorly absorbed. Before they invented carbidopa, basically people would have to take thousands of milligrams of levodopa to even get a response. There's immediate benefits. If you take it, usually you'll see some improvement within a week of initiating the medication. Almost all patients with Parkinson's disease respond well to levodopa. There are some people that are very tremor predominant who might not respond well and need either high doses or other medications to help out. This has been the single drug that we have shown that it reduces disability and prolongs life in people with Parkinson's disease. And again, the addition of dopa decarboxylase inhibitors like carbidopa both improve the absorption and the effects of levodopa alone. I type very poorly, so I'm going to apologize for any typos. So there are side effects of all the medications that we give. Our drugs are potent. They actually go into your brain, where a lot of medications that we use don't go into your brain, such as antibiotics, heart medicine, and all this kind of stuff. So we can cause nausea, vomiting. Orthostatic hypotension is a tendency to feel lightheaded or faint when you change positions, when you stand up. We can cause vivid dreams and also hallucinations with our medications. So motor complications. So what we call motor fluctuations is a tendency for the Sinemet or carbidopa levodopa to kick in and wear off. We call that being on, like your meds are working, you're on, or off, your meds are not working or you're worn off. Usually motor fluctuations, that tendency for medications to kick in and wear off, starts about 3 to 5 years after beginning levodopa. Dyskinesia is squirmy type movements as opposed to a rhythmic tremor. So as you know, with Parkinson's disease, you can have tremor, slowness, stiffness as presenting symptoms, and side effect or dyskinesia is a little bit more squirmy and dance-like. And that only occurs when the medications are kicked in or working. Dystonia is another term that we use, which is abnormal posturing. So people can have foot dystonia, like the foot might turn in or toes might curl. Sometimes people have dystonic posturing of their hand or arm on their predominant side as well. And that tends to occur when medications are worn off. But in weird cases, it can also happen when people have dyskinesia. That's rarer. So I have a lot of patients that are worried that levodopa is a toxic medication to take and that it makes Parkinson's symptoms worse. There's actually no data to suggest that. In fact, there is some data that suggests that that levodopa, carbidopa-levodopa, may slow the progression of the disease, but that was not proven. It's from an old study performed many, many years ago called the L-DOPA study. Motor complications, again, motor fluctuations and dyskinesia. People sometimes think that has to do with exposure to levodopa, and it doesn't. It actually has to do with progression of the disease. As we unfortunately all have learned, is this disorder is one that you have slow worsening over time. And because of the changes that occur in your brain cells, because of progression of the disease, it makes people more susceptible to having dyskinesia and a tendency to wear off. Does that make sense to you all? Pretty much. And again, people are really, I've been working in movement disorders now for 21 years. People are fearful of having dyskinesia. And what I try to say is that might just mean your meds are working if you have advanced disease. And so why does it happen? Again, there's cellular changes with the progression of the disease that makes cells susceptible to causing dyskinesia with exposure to levodopa. And then what do we do to treat it when people develop dyskinesia? If it's troublesome, we might just back off on the amount of levodopa people take. There are some medications that we specifically give to temper dyskinesia in Parkinson's. And is it a bad thing? I personally don't think so. If I poll 100 people with advanced Parkinson's disease who have wearing off and who have dyskinesia, if I say that let's choose between two devils, which would you like to spend more time with, being really worn off or being meds working with some dyskinesia? And almost everybody will say that they'd rather have the meds working. Okay, so levodopa, we take it by mouth. It's absorbed into our blood and it has to cross the blood-brain barrier. And then it's then taken in to nerve terminals and converted from levodopa to dopamine. And then it's like you have more dopamine in your system. Dopa decarboxylase inhibitors are medications in the US, primarily carbidopa. And so what that does is by inhibiting dopa decarboxylase, you essentially make it so you have better absorption of the drug. And with better absorption, then you will have more of the drug that passes into the blood-brain and over the blood-brain barrier, so you have more dopamine created and available. You can still get straight levodopa. I've literally only used it in one patient in 21 years who we thought might be allergic to carbidopa. So, essentially we don't order straight levodopa when we start medications. We start with carbidopa-levodopa. Parkopa, so there's a bunch of different brand names. Parkopa is orally disintegrating carbidopa-levodopa. Rytary is a high-tech, long-acting formulation of carbidopa-levodopa. Adamet is another a brand name that's not as common as Sinemet. So our bodies make things and break down things and recycle chemicals in our body. So you use enzymes that break down, they catabolize the things. So if you have COMT, which is an enzyme that breaks down dopamine in the brain and also in the, actually in the whole body, not just in the brain. But if we block COMT, then you effectively have more dopamine that's available in the brain because we're blocking an enzyme that breaks down dopamine. So if you take a COMT inhibitor, you always take it with levodopa because it doesn't do anything if you take it by itself. There's 3 main COMT inhibitors that we use. Entacapone has been around forever, also known as COMT. Tolcapone has been around forever, also known as Tasmar. A lot of docs don't prescribe Tasmar or Tolcapone just because of other hassles with liver function tests you have to monitor. And then we have a new drug called opicapone, which is a really nice once a day COMT inhibitor that can be used to increase on time and reduce motor fluctuations in people with Parkinson's disease. So essentially, you block that enzyme and you have more of your own levodopa or your own dopamine available. So there's more enzymes that break down dopamine. Monoamine oxidase type B is another enzyme that breaks down dopamine. And so we recycle in the synaptic terminal, we recycle and uptake dopamine that's not used, and then it's brought back into the cell, and then it's metabolized. So if we block the other enzyme that breaks down dopamine, then we have yet more of your own dopamine available. Does that make sense? So some patients, we give medications to block both the enzymes. So it's not just one or the other, but you can take both COMT inhibitors and MAO-B inhibitors together. So the MAO-B inhibitors, some of them are FDA approved to be used in patients that is monotherapy. So that means if somebody comes into the office and we just diagnose them, we might put them on racetabulin to improve their symptoms slightly. And then later on, if somebody is having motor fluctuations, if they're wearing off, we can add in these drugs to improve wearing off. Dopamine agonists. So when I first started, several years ago, dopamine agonists were kind of new on the market, and we thought, oh my gosh, we can give these drugs, and they basically are like synthetic dopamine. They'll come in and they essentially stimulate dopamine receptors, but over time we found out they do have some side effects. So ropinirole, pramipexole, so that is Requip, Mirapex, rotigotine is Nupro, that's in a patch form. I don't know if any of you are familiar with the skin patch. And then we have another one that's called apomorphine, which is used right now as an injectable rescue medication to treat motor fluctuations. So side effects of dopamine agonists, the biggest side effect is people can get sleepy. And about 10% of people that take these drugs can have significant sleepiness and, in fact, sleep attacks. So, you know, you're driving down the road and you like fall asleep driving. That's not a good thing. So you have to be careful when you initiate these medications to make sure that you're not getting too sleepy as a side effect of the medication. Actually, you can read it a little bit better here. So you can take them again alone or with levodopa if you have wearing off. They are longer acting than levodopa, except for apomorphine. There's a less of a tendency to produce dyskinesia than if you take levodopa alone. So in some people, we will have both medications on board to be able to give a little bit less levodopa to have less dyskinesia. Then there is our impulse control disorder. So that has to do with stimulating the wrong dopamine receptors that would be such as a tendency to gratify yourself. So I call some of these medications, they stimulate the woohoo part of the brain. So that, like, have you ever won anything? I one time won a door prize at a bridal fair, and it's like you get all excited and kind of get this rush in your body. And so we don't want to stimulate that part of the brain because that causes people to be kind of compulsive. And so you might have hypersexual behavior. You could have excessive buying behavior, gambling, hobbyism. And before we knew, so I date back to the time that we didn't know that this was a side effect. And we had some, patients that started gambling, say, and they were gambling their life savings away, but they were coming to the neurologist and they were coming for their Parkinson's, but not to admit that they have a gambling problem, right? And so once we put that together, that this can cause compulsive behavior, I started asking people when they would come in, and my little 30-minute appointments became hour-and-a-half appointments when you realize that the drug that you've given has caused bad behavior. And in fact, we had people that lost their life savings, they ended up divorced. It can be bad. So you do need to know about that as a side effect. And the weird thing about that is people don't necessarily recognize that what they're doing isn't right. And so spouses, care partners do need to know that as a potential side effect, because then they can observe that my loved one's had a behavior change and maybe it has to do with the Parkinson medication. All right, and again, what they do, the dopamine agonists, they come in and they stimulate dopamine receptors without having to be absorbed or converted to dopamine. Anticholinergic medications, they've been used in the past pretty widely. That was very commonly prescribed. And it's really, anticholinergics are good for people with real strong tremor. As you know, Parkinson's disease, there's tremor, slowness, stiffness. Some people have almost pure stiffness and slowness. Other people are almost pure tremor. And then there's everybody in between. So anticholinergics are really good for somebody who's very tremor predominant with Parkinson's. But the side effects are pretty big: dry mouth, dry eyes, constipation, mental fog. And what we also found out, there have been recent studies that have been published that people that we have chronically on anticholinergic medication can actually have a dementia if you leave them on the drug too long. So trihexyphenidyl or Artane is the most commonly prescribed anticholinergic, and there's also another drug called benztropine or cogentin. That's rarely prescribed. Amantadine has kind of a unique mechanism of action, and that is another medication that can cause dry mouth, dry eyes, constipation. It can also cause kind of a funny, blotchy appearance to the skin, particularly in the feet or the arms. That can be a very effective treatment for tremor, and it also can be really effective to temper dyskinesia. Amantadine comes in the old-fashioned amantadine, and then there's a new high-tech formulation we call GoCovery, which is something that is available. So, adenosine receptor antagonists. This is a type of drug. It's newer on the market. Istradefylline or Noriance is the name of it. It's such a complicated mechanism of action that even some neurologists have a hard time describing it. So basically, there's this part of the part of the brain called the direct and the indirect pathways, and that's like putting your foot on the gas and putting your foot on the brake to make movements faster and slow movements. So in patients with Parkinson's, dopamine levels are decreased, which reduces the indirect pathway. So it reduces the activity of so you have a no-go pathway, putting your foot on the brake, and it increases the direct pathway. And so what these drugs do is they basically help modulate the foot on the gas and foot on the brake to smooth out movements. It's complicated, and whenever I talk about these drugs, I have to restudy the mechanism of action. It's just something that's super complicated. So if we block the foot on the brake, then you'll have more foot on the gas. Does that make sense? So if you foot on the brake would be medication's not working, foot on the gas, medication's working, we're kind of modulating that. So there's a new term that we're using called device-aided therapies in people with Parkinson's disease. And this is for people with more advanced Parkinson's. So I'm having wearing off, I can't control my medications in spite of taking a bunch of oral medications. So DOPA, which is a pump of levodopa, carbidopa, it's a gel form that you have a pump surgically implanted that, well, the pump isn't implanted. There's a tube that's surgically implanted and it connects to a pump. And then you can have a continuous infusion of levodopa. It goes straight into your jejunum. It doesn't go into your stomach. It goes farther down the line in your GI tract to where it's actually absorbed. So levodopa is actually not absorbed in your stomach. It's absorbed further down the way. That can be really helpful for people that we just can't control the motor fluctuations because oral medications just aren't working well enough. Deep brain stimulation is another therapy that is a surgically implanted therapy with a stimulator, basically, that overrides a bad signal in people's brains. But it is brain surgery, so it's kind of a big deal. And then there's also lesioning surgeries. So before we had DBS, with some movement disorders, they would put an electrode in the brain and then they'd turn the electricity on and it'd heat up and it'd burn out a little area. You'd lesion an area out of the brain. So people with tremor, you lesion the part of the brain that is responsible for tremor, and then you have improvement of tremor. So those were thalamotomies and subthalamotomies. Those are old types of treatment, but now there's a lot of news about ultrasound. So if you take focused ultrasound and you target the area of the brain that is responsible for your movement disorder, it'll heat up that area, and then you have improvement of symptoms like tremor. But it's kind of like they don't do a burr hole. You put your head in this big device and then it focuses the ultrasound, but you still get a lesion. They still do kill off some cells in the brain. So it's kind of like a non-surgical surgery. Yes?
I just was reading something online a couple of days ago, and I was going to print it and bring it, and I forgot it. They talked about deep brain stimulation and non-invasive brain stimulation.
That's
Is
this.
that what you're talking about?
Yeah. So they basically, they don't cut you with a knife. They focus waves into your brain. So it is still a lesioning surgery. So, oh, yes.
So by using this ultrasound, because I would not qualify for a deep brain stimulation because I have a atrophy in one of the folds, would that work?
So usually with, qualifying for brain surgeries, there's certain things that are kind of not smart to do surgery on people. If you have atrophy, that might mean that there might be some memory and thinking changes. And so if you alter the brain cells and somebody has some pre-existing problems such as excessive atrophy, which means shrinkage in certain parts of the brain, or if there's any memory and thinking changes, they can make that worse by doing surgery. I don't know specifically about the focused ultrasound, if that would be, I don't have enough practical use. We only have a couple of people, and they don't have Parkinson's disease. They have another disorder called essential tremor. So I think we need to do a little literature search to find out if that disorder can worsen memory and thinking. So alpha-synuclein. So now I'm going to completely back up. So we all have a protein called alpha-synuclein in our bodies. In people with Parkinson's disease, there's something wrong with the alpha-synuclein. And so every protein has a structure, right? So if you have Parkinson's disease, there's an alteration in that structure. So it gets kind of folded together, and then it can kind of glum up in brains. It will start sticking together. And if you have this accumulation of abnormally folded alpha-synuclein, you get these inclusions called Lewy bodies in the brain, and those are present in the cells of people with Parkinson's disease. So what we think is that you have this abnormal folding and then this accumulation of Lewy bodies and this excessive abnormal folded protein in the cells. And then our bodies try to get rid of this stuff. Again, we get rid of junk that our cells don't need, and we make new things out of it. And the mechanism that we get rid of it kind of stops working, and then you get more and more accumulation, and then you have more disease in the cell. So what we're also thinking in people with Parkinson's disease is this misfolded protein. It ends up kind of leaking out of the upstream cell into the in-between cells, and then it gets picked up with the downstream cell, and it's then the downstream cell will end up with misfolded protein. So they call that a prion philosophy. But what we want, so this is a picture that doesn't really show very well, but you've got a nice normal alpha-synuclein that becomes misfolded, and then you start ending up with it clumping together, and then it ends up accumulating in the Lewy body. So interesting, if you look at people, there's this Dr. Bracht, who's a pathologist, German fellow, who looked at brains of people in all different stages of Parkinson's disease, and he was able to extrapolate it down to people that were pre-symptomatic, so they didn't have enough cells that had been damaged to even go see a doctor. And so what they found is Lewy bodies initially accumulate in your olfactory lobes. They kind of are at the base of your brain. And also you'll see them in the vagus nerve in the GI tract. So they think that whatever it is that turns on Parkinson's disease might be an inhaled toxin or something you ingest. I talked a little bit about that prion theory, where, if you have cellular changes in the olfactory, then it will spread by this kind of, from one cell to the second, to the next, to the next. Do you remember hearing about the fetal transplants that they did many years ago, where they put fetal cells, dopamine producing cells, in the brains of people with Parkinson's disease? And with that, the people have naturally died, and they've been able to obtain those brains, and they find out these teenager brain cells, the fetal cells that are like 10, 13 years old, have Parkinson's disease too, which has actually helped us understand, unfortunately, how the bad protein gets from cell to cell. It's not that they're just getting old and getting this. Even the teenager cells end up with Lewy bodies in them.
You can have Lewy body dementia that's totally separate from Parkinson's.
Yeah, that Lewy body dementia is separate. It's technically separate, but I think over time we're going to find out there's a whole spectrum of Lewy body dementia to Parkinson's dementia and everything in between. It's a little confusing. So Lewy body dementia patients also have Lewy bodies.
Right.
Like, yeah, but it's just in a different part of the brain. So they've also done some studies where they take the misfolded alpha-synuclein and they inject it into, say, animals, and then the animals will develop Parkinson's because, you know, we've given that misfolded protein to the cells. So what are we going to do? How can we stop this? And so now there's some new research that is intended to clear out that misfolded alpha-synuclein from between those cells. So we're doing studies right now in anti-alpha-synuclein antibodies to see if we can slow the progression of Parkinson's, which is pretty cool if it works. So that's, you know, not everything works, but right now we're studying that. There's a couple different devices that are not on the market now that are actually at the FDA. And so we have done some studies with subcutaneous pumps rather than a big giant pump that's threaded down into your jejunum like DOPA. This would be a pump similar to an insulin pump. Anybody know anybody with an insulin pump with diabetes? So of course this person does. But anyways, so instead of having, it is invasive because you have like a little subcutaneous needle that you pop in, and it threads into a small little pump that will continuously give medication to treat Parkinson's disease in a subcutaneous injection. Pretty cool. So we're looking at different formulations of levodopa that are 24-hour subcutaneous pumps, and also a drug apomorphine, a dopamine agonist, that has been available in Europe for many years in a subcutaneous pump, which now we're trying to get FDA approved here, and we might see it next year. So we'll have something else that's for more advanced disease that we can have better control, which is nice. So again, we're looking at anti-alpha-synuclein antibodies. We're looking at new inhaled treatments to be used as a rescue treatment. Ambrosia is actually one that's FDA approved. That is levodopa. That is an inhaled treatment for unexpected wearing off. There's studies being done to treat mild cognitive impairment and also dementia in people with Parkinson's disease. So Parkinson's disease dementia, Lewy body dementia, those are different than Alzheimer's disease. And so they're looking at specific treatments. You know, that right now is kind of going to be the olden days, because the drugs we have right now to treat dementia with Parkinson's are actually Alzheimer's medications that we're using off label, except for one. LRRK2 is a gene that people have that will actually create enzymes that promote or accelerate Parkinson's disease. And some people have an LRRK2 gene specifically that we think is responsible for a more aggressive, faster course of illness of Parkinson's disease. And so we are looking at drugs that block that gene, and then it slows down the progression of Parkinson's disease. And then there's also some other gene-targeted therapies for people with, there's other genetic mutations like GBA mutations. I think this is probably where a lot of the research is going to be going, is looking at other genetic variations of Parkinson's disease. We right now can commercially test about 25 different variations of Parkinson's, and so, or genetic variations of Parkinson's disease. And so, like in oncology, they are doing gene-targeted therapies to treat different tumors and different cancers. And so I think the future is going to be gene-targeted therapies for genetic variations of Parkinson's.
Is the distinguishing factor with Lewy bodies PD the hallucination?
People with Lewy body disease, specifically people with Lewy body disease, have slowness and stiffness and/or tremor that develops about the same time that there's some cognitive impairment. So instead of, so you see memory and thinking problems up front. And so those people tend to have kind of good days and bad days and fluctuations in their memory and thinking. And also they're predisposed to having hallucinations. And sometimes people can hallucinate with very minimal medications. And in some cases, people can have hallucinations even without medicines with Lewy body disease. Where with Parkinson's disease, memory and thinking is later, it's not up front. And in people with Parkinson's disease dementias, you can also hallucinate from meds. Yes?
You're talking about new medications for cognitive impairment. Is there something on the market now that would help somebody that it's, I don't want to say confusing, but when they're trying to think things through, it's more difficult than it used to be?
Yeah, so with memory and thinking problems with Parkinson's disease and also DLB, or dementia with Lewy bodies, there's different realms of memory. So there's short-term memory, abstract thinking, which is like multitasking, figuring stuff out, problem solving, and word finding are the three main areas. And so there's one commercially available drug that's been tested in people with Parkinson's disease, and that's the rivastigmine patch or the Exelon patch. So that can be helpful sometimes. Although we do also prescribe other medications that are Alzheimer's medications. Let's say somebody has skin reactions to the patch or something, so we might go to an alternate medicine. But we don't have a lot of mild cognitive impairment or dementia treatments for Parkinson's specifically. And thank goodness for doing a lot of research, right? Okay, so this is little Miss Maisie at her 2nd birthday. She's a little Havanese. So any more questions? Yeah. Oh, actually, interesting. So with melanoma and Parkinson's disease, we used to think that levodopa caused melanoma. And we did a study. Dr. Kumar actually was involved in this study. We were the highest enroller in the country of this study of this drug that we thought might stop the progression of Parkinson's. In animal models, it stopped Parkinson's or really slowed it down. And so this study, we enrolled, I think there were maybe 300, 500 people, and we were looking at to see if this drug caused melanoma. And so they had dermatologists looking at everybody in the study very frequently. And what we found out is the people on placebo also had a higher incidence of melanoma. And so what we're thinking, because of that study that was a failed study, it didn't work, but the dermatologists looking at people with Parkinson's, we found out that there's probably a genetic predisposition in people with Parkinson's disease to develop melanoma. And so the recommendation is, when you diagnose somebody, is to say, you may have never had skin problems, but you should go see a skin doctor once a year for a look over. And I've actually seen several people that develop melanoma, unfortunately, with Parkinson's disease. So, yes.
Is there a difference between MAO inhibitors and MAO-B inhibitors?
There is. So there's different types of MAO in our body. So there's MAO-A and MAO-B. So MAO-A is the treatments that are MAO-A inhibitors are actually some of these medications that we use right now, like Selegial in higher doses, and that's to treat depression. And so, and those are old drugs.
Right.
And so in the olden days, which my nursing career, we used to see this, is people that, psychiatric patients that would have a lot of tyramine in their diet would end up with a hypertensive crisis, and it was a life-threatening crisis. But MAO-B does not do that.
Oh, that's good.
Yeah, so there's a fear from some providers to prescribe MAO inhibitors that they're going to cause that hypertensive crisis, but it's the wrong MAO.
Okay.
Yeah.
I have a couple of questions. Is there a limit on dosage on the LEVODOPA that we can, because I have a advanced already, and so I take like 7 pills already. So is there going to be a limit to how far I can go on that?
That's kind of a complicated question. It depends upon the provider. The 7 pills a day is not high in our office. We have people on, 15 pills a day. But there's some theoretical problems giving high doses that we've never seen. So in our center, we're a lot more comfortable with giving higher doses. And that's, when you limit the amount of Sinemet or medication, Parkinson's medication to give people, then that kind of will cause more disability because the people have the wearing off and their meds aren't working and they're not functioning well at those times, as opposed to when they take their medicine. So it's primarily the provider who's prescribing level of comfort.
And another question, Amantadine, can that be taken as needed, or does that have to be?
Amantadine is usually not given as an as-needed medication for treating Parkinson's. That's usually regular. Yeah, it can be used for dyskinesia, and it also can be used to treat tremor.
Well, I use it for dyskinesia. I don't get dyskinesia all the time, so I take it only when I get dyskinesia.
It works, so Amantadine tends to work better if you take it regularly. Yeah, because sometimes dyskinesia, people, if you get excited about something, you might really get dyskinetic. Or I thought I was speeding a little bit, driving down here, and I'm sure if I had Parkinson's disease and I got pulled over by a cop, I would probably be really dyskinetic just because anxiety. So sometimes you can't predict when that's going to happen. So if you take it regularly, then you kind of better coverage through the day.
So what's the connection between stress and increased tremor? Or cold and increased tremor?
Adrenaline.
Oh, okay.
It's like a stress response, and that makes everything worse. All movement disorders. If it's Huntington's disease, it'll make chorea worse. If it's tremor, straight tremor, it'll make tremor worse. It'll make dyskinesia worse. Adrenaline is not really our friend. Yes.
So relatively new to this, so this might be, but the key to all of this is the dopamine.
Correct. Dopamine is the dopamine cells in Parkinson's are the cells that are, are not working well.
Is levodopa just an artificial dopamine?
Levodopa, actually, what happens is you take it and then it's absorbed into your brain, and inside the brain, then it's converted from levodopa to dopamine. So you have more dopamine. So it's quasi-artificial, but it ends up the same chemical that our brain has.
And is there a natural way? I mean, is levodopa manufactured, or is there something you could eat, something you could?
There are natural ways that you can get more levodopa. One is eating fava beans. 100 years ago, I had a patient who's like, I'm not taking this pharmaceutical product. I'm just going to eat fava beans. So he was eating plates of fava beans, and he came in for his next appointment, and he says, if I see another fava bean, so there are some natural herbs like mucuna that can replace, but that doesn't have carbidopa in it, so it's not very well absorbed. And unfortunately, we don't know how many milligrams people are getting because the mucuna, that the whole vitamin and supplement is not FDA regulated, and so that it's not real rigorous, and so we don't really know how much people are getting. So.
You didn't mention Miraplex with carbidopa.
Mirapex or pramipexole is a dopamine agonist. I'm sorry, that's probably a typo. So Requip, Ropinirole, Mirapex, pramipexole, Nupro, rotigotine, and apomorphine are the 4 dopamine agonists that we have. Yeah. All right. Any other questions? Questions off medication topic that you need? Very good. Well, thank you.
Yeah, it's nice. I like
Yeah.